Okay, so we're going to talk about several conditions in this section because most of them are a little bit shorter. We're going to start with primary pulmonary hypertension. Pulmonary hypertension is when the arterioles to the lungs are constricted. So remember, the pulmonary artery takes blood to the lungs to get oxygenated, and then blood goes back from the lungs to the left atrium for circulation. So the right ventricle that's trying to send blood to the lungs, if those vessels are really constricted, it's going to get the right ventricle is working against high pressure. Okay, so it's called pulmonary hypertension. The right ventricle starts to hypertrophy, it starts to overgrow, the muscles working harder and harder to push blood through those constricted vessels. What happens to muscles that work hard? They get bigger. So the right ventricle starts to get too thick, and then we have decreased blood that can fit in the right ventricle. We also are going to have the tricuspid valve, that when the ventricle is trying to push blood through the lungs and it won't go through those pulmonary arteries, some of that blood is going to regurgitate back up into the right atrium. So we have some regurgitation, and that leads to systemic vascular congestion, CHF. So what does it look like? This person gets fatigued because we can't get oxygen. If they can't get the blood through the lungs, they can't get oxygen to their tissues. So they're fatigued, they're short of breath. They get short of breath with any exertion, okay? The complications, any decrease in venous return means the lungs get even less blood. So it's really critical that blood that goes down to the feet comes back up. That means we cannot let them lay on their back. We cannot let them sit and have all the blood pooled in their legs. We've got to, we want to use stockings. We want to avoid the supine position, have them on their side, okay? If they get hypotensive, if we let their blood pressure get low, we may not be able to get it back up, okay? The mortality rate for this in pregnancy is up to 50%. Labor and the immediate postpartum are the most dangerous. So this is a really dangerous condition to get pregnant. Pregnancy is not advised for these patients. Sometimes they get pregnant anyway. During pregnancy, we want them to limit activity, never lay flat on their back. We want them on their left side. They need diuretics for the heart failure. They need oxygen because they can't get enough, because they can't get the blood through their lungs well. Vasodilators are meds that are given to try to open those vessels up to the lungs better. In labor, they need an epidural, but epidurals have a side effect of hypotension. So we've got to make sure that we're doing everything to prevent them from getting hypotensive, because remember, blood pressure drops, we may not get them back up. And we've got to prevent blood loss to maintain blood pressure. The next is peripartum cardiomyopathy. This actually is something that happens in pregnancy, not pre-existing. It's when the patient develops congestive heart failure in the last month of pregnancy or the first 5 months of postpartum, with an ejection fraction of less than 5% and no other cause for heart failure. They don't know what causes it. It seems to be just an idiopathic thing. The risk factors, this is more likely to happen in patients older 30 who've had lots of kids. It's more likely to happen to people of African descent. Obesity is a risk factor. Tocolytic meds, that's meds to stop contractions, increase the risk. Preeclampsia increases the risk, and chronic hypertension. What does this look like? It looks like congestive heart failure. So what does your CHF patient look like? Also, you'll see an enlarging heart. Management is CHF management, sodium and fluid restriction, diuretics, things that reduce afterload. So we want to reduce blood pressure so the heart doesn't have to work as hard to perfuse. Digoxin is given to increase the strength of those of the heart contraction. If they're at increased risk for blood clot, they need anticoagulants. In the postpartum period, they may get ACE inhibitors to vasodilate, but they can't be given in pregnancy because they can affect the fetal kidneys. They're probably going to have, we want epidural anesthesia and a vaginal birth. So no pushing, but also we want to avoid C-section. About half of these cases go away in 6 months with a good prognosis. If they don't go away in 6 months, the mortality rate is 85%. The next thing we're going to talk about is infective endocarditis. It's not common in pregnancy. It's an inflammation of the endocardium, the lining of the heart. Risk factors, major risk factors, IV drug use, okay, because using dirty sets. Anyone who's had corrective surgery for any kind of congenital heart defect is at greater risk, because if you have anything in your heart that didn't grow there, or if you have that scar tissue from surgery, if bacteria get into the bloodstream, they're more likely to infect it. The complications of endocarditis, we can have heart valve damage, we can go into CHF, or if those valves are the valves are damaged, we can have some blood pooling and clots, but also those clusters of bacteria, they're like vegetations on the valve. Sometimes they'll break loose and they become an embolus and we can have a stroke. Managed by antibiotics. Only people at very high risk get prophylactic antibiotics, but if someone has this, they get antibiotics. Eisenmenger Syndrome is associated with a structural defect, either a ventricular septal defect, an opening between the ventricles of the heart, or a patent ductus arteriosus, which is when the pathway between the pulmonary artery and the aorta doesn't close after birth. What happens with Eisenmenger syndrome is they have shunting. Blood that's supposed to be on the right side of the heart going to the lungs gets shunted over to the left side, going back out to the body without picking up oxygen. So anytime there's increased resistance in the pulmonary vessels, because they've got those openings, blood will shunt over to the left side, so they're not oxygenating blood. This is associated with 50% maternal and fetal mortality. Sudden death can occur anytime, but in labor and early postpartum are the most dangerous times. Management, again, pregnancy is not recommended, and if someone with Eisenmenger syndrome gets pregnant, they may be advised to terminate. The goal is to maintain adequate pulmonary blood flow. So if they decide to continue that pregnancy, then everything in that pregnancy is focused on making sure we get blood going through the pulmonary vessels. Limit physical activity. We want pressure graded support hose. So if we've got difficulty getting blood into the pulmonary vessels, why does it help to put on support hose? Well, if we have blood pooling in the legs, then that's less blood to go through the pulmonary vessels. But also, if we increase the pressure, so we make it a little harder to get blood to go through the periphery, then that makes it a little easier to get blood through the lungs at times. So support hose, they need oxygen. They may be in the hospital antepartum. In labor, we cannot let them get hypotensive, so they need narcotic-based anesthesia. So they need an epidural with narcotics, not paralytics, okay, not canes, okay. They cannot let them get hypotensive. Did I say that enough times? Fluid overload also has to be avoided. So we have to walk a really fine balance with this patient. This patient is not going to tolerate a C-section well. They're not going to tolerate surgery well. So it's best to avoid a C-section. Marfan syndrome. Marfan syndrome is an autosomal dominant disorder that is a generalized weakness of connective tissue. People with Marfan syndrome tend to be very tall, gangly. They may have joints that dislocate easily. They also may have aortic root dilation. The aorta may actually be larger than it's supposed to be and develop dilation almost like an aneurysm. So the complication is that when we add the increased blood flow of pregnancy, that actually may cause the aorta to dissect or to rupture. Maternal mortality is 50%. That varies based on the size of the aortic root. So again, this is a genetic disorder. So on top of the 50% maternal mortality rate, now there's a strong chance that they're passing either at least the trait to their child. And so It's actually autosomal dominant. So there's a chance they're going to pass that to their child, 50% chance. So preconception counseling is really important. If they're before pregnancy, if they can have the aorta repaired, that lowers the risk. In pregnancy, we want restricted activity. They need beta blockers because we don't want to increase their heart rate. We want to prevent tachycardia. Okay, we really don't want them working harder because we don't want to risk damaging the aorta. If the aorta is less than 4 centimeters, they should be able to give birth vaginally. For larger defects, sometimes C-section is chosen. There's not a lot of research that indicates which avenue is safer. We definitely don't want them pushing them. Valve replacement. If someone has a valve replacement, artificial valve or a transplanted valve in the heart is going to be a potential site for blood clots. So typically they are anticoagulated all the time. In pregnancy, there's a risk of hemorrhage with anticoagulant. And so we balance the risk of the thrombosis with the risk of hemorrhage. Bioprosthetic valves don't always need to be anticoagulated, but pregnancy tends to degenerate those more quickly. Mechanical valves last longer. They require anticoagulation, and if they have to be replaced there are no anticoagulants that are safe throughout the whole pregnancy. So they're chosen based on what's the lowest risk for that stage. If they're on Coumadin or low molecular weight heparin, that needs to be stopped before labor, and heparin is started because heparin is easier and faster to reverse. In labor, they are on no anticoagulants. And then in the postpartum period, their anticoagulants are restarted. Heart transplant patients, this is where the good news comes in. Before a person who's had a heart transplant needs to have a preconception assessment. They look at ventricular function, they look at the risk of rejection. If they're stabilized on their meds and they're at least 1 year post-op and they have good ventricular function, low risk for rejection, then the prognosis for pregnancy is really good. Okay, complications of pregnancy for heart transplant is hypertension or potentially going and rejecting that organ. Okay, we're going to talk next about anemias in pregnancy.